Ah, good. Okay, this seems to be partial thickness tear and supraspinatus.
Yes,
Yeah.
with the
Yeah.
um, comminuted enthesis of some
Yeah.
form.
Now, this one, I don't normally bother to record partial tears just because they're so common. This one, it looks here as if it's torn on the deep surface. When you go a bit further into the video, and it looks like there's a defect in the bursal surface as well. So it you'd have trouble describing that. It'd get a bit long-winded, but there's more long-winded than I like to be. I like to be able to just say something really simple.
On that
Uh,
last one, if you had to guess a percent
yeah,
of cross sectional area that remained viable, would you be saying we're at about 50%? Would you, because it looks to me like at least the anterior fibers, it doesn't look
yeah.
like it's a
This is a
complete,
small tear.
yeah,
This is a
okay.
small tear,
Oh,
and
okay.
even though it's on both sides
Yes.
of the tendon, it is still less than 25% of
Okay.
the tendon. I would have said in terms of depth across.
Yes.
And when you look in short, and I haven't got a good, there's the biceps here,
Yes.
and the tear is just located here. So all this bit of tendon is all fine,
Yes.
and probably a little bit on the side here. So in terms of cross-sectional area, it's difficult because you don't know whether it's extending a little bit out to here, but
Yeah, yeah.
there's and those elements of deep and superficial tear. But you're going to have 80-90% of the tendon is still intact, I would have said, by number of fibers. So this is definitely in the region of a, a relatively small partial tear,
Surgical
and a little
decisions
bit acute.
surgical decisions here are made from an insurance standpoint at about 50% of tear. And so it's one of
Yeah.
those things that you just go, huh? Will this, what percent of, what are the chances that this scan will be elevated, or should I say lateral, to MR tomography?
In terms of zero, probably, or not. In our, we would manage the vast majority of these. This was taken in what we'd call primary care service. So this is a service where there's before a patient is considered by the surgeons, and the vast majority of these we treat very successfully in primary care with physio injection and injections typically, and time.
Yep.
And even when I follow these up or similar cases up uh, a year or two later when I'm doing my long-term reviews, a lot of them that even those of them that actually get in front of a surgeon, by the time they get in front of the surgeon, symptoms have settled even when they've given up on physio. They turn up at the surgeons and they say, actually, having stopped worrying about it and have become non-acute, I get good function here. And though I sit and chat with our surgeons and they're very much proactive in terms of the younger population, that they think that surgery is a good idea for younger people with tears that they're going to progress. By the time they get to see them, the patients are going, no, thank you. And we probably need to sit down and do some 20-year follow-ups, but we need good data on what the tears are. So it's probably our cohorts just in the last 5 or 10 years that we need to follow up over 10 years and 15 years and say, what's the long-term prognosis on it? But, patients tend to get better rather than worse, I think, even in the medium term that I can speak with some confidence about. So I'm not really worried about these guys not getting surgery if they don't want it. So it's not big money. It doesn't. It's not the sort of thing surgeons want us to be too enthusiastic about. But I won't discuss that because I haven't got the histology on that one yet. So there's no point in speculating on what that
But
was.
this was a soft
So
tissue mass.
yeah, that was just a little soft tissue mass in the hand. But until we get feedback on it. There's no point in
Yeah.
chatting about it. That will be somewhere down the line that will turn up on one of my lists. Right. So this you know all about.
This is, I would say, supraspinatus calcific, the CPPD type thing.
Yep. Yes, calcific tendinosis, I would
Yeah.
describe that as. And I would say it was late stage. So if I stuck a needle in that, I would be optimistic about getting something out. I might not be. I can't remember what. I don't think I might have put a needle into this, but not much came out, I don't think. But that's the sort where I would expect to often get quite a lot of chalk out when I stuck a needle in it.
Earlier to this,
do,
earlier to this, would you be taking out more clear material, or would
no,
you say so?
no, it's when it's soft, when you can see through it, it is often a bit like toothpaste. And so when you stick a needle into if you could stick a big enough needle and flush some fluid, you will often get calcium back in as you flush into your syringe. When it's harder than this, you get much less out, typically, but you're more breaking up something that is slightly more solid, so you get much less out.
When you say when you see through it, if you had to talk to me about the stages of what we're looking at here, do we create that posterior shadowing as it matures to more calcific echoes, or how does how does your inability to see through it vary with the tenure of it?
Well, the textbooks say that that it arrives, it matures into a hard, crusty, solid thing, and then it ages, and then it softens up and is then becomes softer and more putty-like. Whether that is actually true, I haven't sort of personally sort of followed them through and demonstrated that, but that seems to fit with what we see clinically. So the sound goes through it. I can see the underside of it. I can see texture in it, and therefore it is relatively soft. When I put a needle into that, it will go into it much more easily than it would when I don't.
And relatively soft means it's in the last 25% of its life cycle.
That's the sort of thing they say in the literature.
Okay.
But, we don't, because we don't generally do long-term follow-up. What I do, or what I do see, is cases where people have a classic history of sudden onset of pain, and they've had previous report where there's something like this has been described, and then all I see is some debris in the bursa, and then a very collapsed looking cyst, a bit like when you see a ganglion flattened up. And I trust the people who did the previous scan, and they saw something with a volume like this, and then you see something that looks very flattened, and you think, oh, and they have that classic story, either that it's got a lot more painful, or more often it's got a lot more painful, and now it's started to settle down as it starts to resolve. And so that goes nicely with the story that we tell of these things sort of settling in their own time in a sort of explosive way that for some of them, it comes out all of a sudden. It decompresses all of a sudden. They get a shock of pain, and then life gets better. And that is a story I hear over and over again. So
go back one more time, really quick. Let me ask you this: the fibers of the supraspinatus that are coming out from under the acromion, in that one that you stopped it back there a ways, where we saw the actual structure. Yeah, there. When we see the acromion on the left, and the fibers are coming out from under the acromion and coming down around to the facets and to the enthesis. Can you tell me, do you feel that this mass is basically, we're visualizing it around the collagen strands? Because this is not displacing it like a balloon that was blown up in the tendon. These fibers are going...
I think it is.
Oh, okay, okay. So
I
it is pushing apart, and so it's a space occupying, so that when you say it explodes, it's like pus in an
yeah,
abscess that erupts from out of it. So this we are looking at a vault here. We're not looking at a fibrous going through this structure.
I would like to prove that, but and
Yeah,
I can't. But I never you and I say when you see the texture like this, where it's all very similar, you do wonder. But
yeah,
yes, everything I see, everything I've come across would make me feel that this is a vault, that is
yeah.
a balloon that's blowing up in there.
That's just so substantial to imagine that that dimension in its short axis would be able to
Yeah,
push that much slack out of those fibers that
yeah.
are around it. That's and
I know it's
probably
ridiculous,
explains the pain.
and it's but except that in my shoulder, I think one of my students scanned my shoulder a few weeks ago, and there's very little calcium in there, and you would not believe the volume of calcium that used to be in there,
Ah,
and and just somewhere in my vast library, there are some videos of my shoulder when there was lots of calcium in there. I can't remember where I left them, but they'll be somewhere
yeah,
mislabeled, and I'll come across them. But yes, there's almost nothing there. Last time we looked, it was like
fascinating.
where did all that calcium go? Yes, and it all looked relatively normal, from what I remember. But yes, it's interesting. What's this? Yeah, this is sort of the same old thing I always show you, which is looking at that thickened capsule.
Oh, this is the axillary view of the shoulder,
Yeah, so this is thickened capsule of frozen shoulder. So, and I would describe that as relatively recent onset,
and you
but
you
I don't
you
have
would
any
describe
evidence.
that based on the echo texture and the
Yeah,
darkness of that.
yeah, yeah. And I've got no evidence to prove that that's the way it looks, but that would just be relatively, within 6 months. I think some of the ones that are older than that and have got through the stage, then it becomes less obvious. I still reckon I can see it, but it's not as dramatic. The difference in texture is not as dramatic.
This then
So
just gets
that's
identified in your notes, and you give them time with some
yeah.
gentle exercises, or are you hydrodilating these?
Oh, I inject them with a slightly more an increased volume of injection. I inject them usually depends on the size of the patient, but in a relatively small build patient, typical lady, I would use maybe 10, 11 mils of fluid. That's less than my colleagues do, but I just not seen the evidence to justify the extra benefit of putting in larger volumes, and it just offends me how little common sense it makes to do these things, because they will often pop at that point. I put in 6 mils, 7 mils, and then just go pop, and you see the capsule go from being swollen to flattening away. So the fluid is running away somewhere. And so what would make me want to put more fluid in? I don't know. So I just put in my 11 mils.
What pops
It's the capsule.
when you go into it?
Yeah, when you do an injection and you push the fluid in,
Yes.
then it gets out somewhere.
Now you're
Either
not
it comes
talking an
back the
audio
way
pop. You feel your thumb go in, and that's the pop.
yeah. Well, you see it on the screen, because if you have a look at, I'll show you a hydrodistension or mild hydrodistension. If I just open up another one of these, and I go search, glenohumeral joint, GH injection. This is just one done at random, so I can't tell you what the quality will be like. let's see if this one's one of them. I'll quicken this up a little bit. You don't want to.
No, I do. I do want to watch the entire thing.
Yeah. See, can you see the needle getting into the joint?
Yes.
And then it filling up. Does it swell? No, that was just a glenohumeral joint injection. So let me just find. We go back to there. So we go injection. If I just type in injection, okay. Should be able to find some shoulder injections. No, that's not the right one. Injection. CMC. AC joint. It's probably under shoulder joint. Frozen shoulder injections. This should do. Let's go. We go. Try. Right, so the injecting in there. No, not that one. Let me have this look. We go along one. Let's try another one. One of these ones will show the capsule. There you go. You see this, the capsule distend at that point?
Yes.
Yeah. Now there will be one of them along here, and the thing will just go pop. Let's see. No, let's see. Last bit escaping. I'll be embarrassed if I don't get one of these, but they're usually about. No, you're out of luck.
Every one of these I'm enjoying, so I'm not out of luck. I just even seeing what you are looking at from a. Oh, there we go.
Yeah, it does. That one doesn't pop. That's it. I've filled it up.
Okay.
And then I've finished, and then I take the needle out. Let's see if there's one of them. I'm sure will pop. It's just I don't. I went through a period of recording all of them, and then I got bored and my hard drive started to fill up. And so I stopped. No? Yes. And obviously I try to do it so it stretches it, but it doesn't pop. So that's why I'm not adding enough to make it so. But every once in a while, one of them is really tight. And then they just go and they decompress.
But those were all examples of a delivery of a corticosteroid within the glenohumeral joint.
Yes. They're all, let's say that they're quite a straightforward, they're very straightforward procedure. So
on a given week, how many do you do of these?
Nowadays, probably not, only about one a week, but I used to do about 2 a day. Obviously, a lot more people have trained than when I started. You know, a lot of them by me, so there's less call for me to do these. I think they're fairly fashionable things to do, and people like doing them because so they get done by the others nowadays. But yeah, so I used to be doing a couple of these a day. No, that one didn't go. You might be out of luck. We might have to move on, otherwise you'll get bored. Yeah, so that's what I normally end up seeing. This, and then you put in a little bit more, and it just goes whoosh, and it goes straight back to normal in a matter of a second.
You're doing it
that way,
from lateral to medial.
I see lots of people doing it the other way, and I cannot possibly imagine
You mean
why
they're
they would
doing
do
it?
that.
They're doing this way.
Yeah, they do it the other way. And this way is so simple, so reliable. And as you've just seen me show you 10 or 12, that
Yes.
just the needle just pops straight in
Yeah.
and it goes. And I cannot imagine why anyone would do it the other way. But people reckon the other way is easier. And I'm just not sure how.
Do you think that they would prefer to feel the old bone strike and then bring it up in order for them to do
No,
that?
no. I know some good people who do it that way, and I cannot. You know, uh, they look at me funny and say,
When you
and
do it
it's.
your way?
I mean, when I do it my way, yes, they look and they say, and they say they like to do it that way, and I just go, okay, you know, it doesn't. So there's more than one way to skin a cat. I
Yes.
just think this way is just so straightforward.
All right.
Yeah,
I'll let you go to where
I
you.
got bored of chopping. Yeah, let's go back to our other screen where we're doing stuff that is more. Where has it gone? Yeah. So that was thickened. So that's what I do with them. I just stick a big needle in there, and
But you don't do it in this view. You go back and deliver it in the
no, I deliver it through through the posterior view.
Yes, yes.
It's just such a nice. It is such a nice injection. Fasten the deep foot. No, we don't do that. Let's go and have a look at some more radiology-based ones. So this is a 3-month-old Achilles rupture. Have we got what is this? I am not sure. Oh, there it is. I thought for a second. Now, can you see that picture? Is it too dark?
No, I can see it. It started out long axis and now we're at short axis, correct?
Yes.
Okay. Oh, the plantaris.
Looks beautiful, doesn't it?
Yes, it does. I have
This
found
is a
that to
curious
be.
one. Yeah, the large calcification there at the proximal thing, and I wonder whether it ruptured at the level of the calcification. I wonder whether the calcification was there and it then ruptured at that point.
Not that was a part of the calcaneus that retracted, but that it was an intertendinous calcification that brought about
Yes.
the okay.
I think so. I don't know whether I saved a clip of what the calcaneus looked like, but I didn't get the impression from the calcaneus that was it. I thought that the rupture was proximal to the calcaneus, and therefore I think it's probably a large calcification in the tendon.
Yeah.
And it's been pulled off. Yes, if we go back to the to where we're looking at the tendon here, I think we've got relatively normal looking tendon here. I know it's not my finest hour in terms of imaging, but yes, that's what I thought of that one. And this, a little infected sebaceous cyst.
Neck? Was it on the neck or where was this?
No, it's on the abdominal wall somewhere.
Oh, okay, yeah.
On the chest wall somewhere, I think. But yes, it's so yeah, it was a funny shape though. You see, like a little bottleneck, little dumbbell shaped.
Yeah.
So I suspect the original lesion was in the skin, and then as instead of exploding out into the fresh air, it's exploded down into the subcutaneous layer and created a second cyst.
Yeah, probably overzealous person trying to expectorate it and just jam the sucker down to a lower level.
We've all done it.
That's right. Yes, but we've never had evidence of what it's done to us until that.
Yeah, no.
Fascinating.
Yeah, let's see what we've got here. Yeah, distal biceps rupture.
Snake in a sack.
Yep, exactly that.
That's right.
Yeah. And when I was scanning this one, there was no point at which I could make the tendon look in long section like a properly ruptured tendon, because it does curl up like that at the end.
How
So I
long
couldn't
since
ever get it.
how long since the tear or retraction?
I think this was relatively recent, if I remember rightly. But yes, it was. They don't ever turn up the next day in radiology lists. So, and this is extensor digitorum in the shin. It just really dense fatty infiltration.
Because of extended compromise and no anchor at the bottom, or was this a metabolic problem?
Metabolic or neurological.
Oh,
Denervation.
yeah.
Typical low back, long-term sort of sciatic type symptoms, and then you just get denervation in the leg. I think people are looking at this now. I see a lot of it. It's on my list of things to really try and tie down as to what we can read into these sort of denervation or atrophy type patterns, because these are quite profound. This isn't caused by someone not doing as many stairs as they normally do.
Yeah, I don't know to what extent the diabetic neuropathy or even some of those weird contractile, mesenchymal type stuff. I
Yes.
just.
So do you ever get asked to look for contraceptive devices
in the arm? I've seen
implants?
some.
Yeah.
I've seen some, but only as
Yeah.
a function of saying, "Hey, can I look at that?" Not.
Yeah.
And this is that Norplant.
I don't know which one it is. But yes, this was actually quite difficult to see in long axis.
Huh.
Actually, on what is a relatively good scanner. Some of them are easier to see than others. Usually, you see a nice bright line in long film, but I couldn't get a good long view of this one. But I think it was not the standard model. It was.
Gotcha.
So yes, I don't know what that was. This is an interesting one. Have a look. See what you think about this, Achilles.
Wow, that's some extensive hyperemia. Whoa, that's some deep joint issue as well, or at least.
This is the retrocalcaneal bursa here.
Yeah.
And it extends, or looks like it extends into the Achilles. So if I run that back, we go here.
Yeah.
Yeah. So it extends up.
Looks like it just is like erupting into the fibers of the peritoneum.
Yeah. Yeah. Or certainly into the body of the tendon, natural patch from the deep surface. So that's, I was sort of wondering whether this is just severe tendinosis, but it's not hyperemic at all. And in the end, I decided that I couldn't really see that boundary as well as I would like.
And just
therefore,
a second,
I called this a small fissure.
I want to understand what you meant by that process. it was not hyperemic at all. And when you say it, you're talking the synovium or the area around the bursa. Am I
No, but
not seeing? Oh, you mean
no,
right
this
at the
area here
junction?
within the tendon,
Okay.
this area where the low echo region extends into the tendon is
Yes.
not hyperemic.
We would expect it to be reactive to the flow within the dark area if it would be hyperemic. Is that what you're?
It's more that you've got. If we go back to our picture of the bursa, this is probably to some extent fluid here.
Yes.
Yeah, some of it will just be very low echo material, and some of it will be fluid. And the question is, if this dark period area extends into the tendon, is this a tear in the tendon that is then having synovial infiltrating into it,
Yes.
or is it or is it this just tendinosis here within the tendon?
For you to say that it does not have the hyperemia that you would expect, would that darker area show more of the Doppler reactivity for you to say that is hyperemic?
Well, it was this area, this low echo area that is within the confines of the tendon.
Yes.
These are sort of area here. The question for me is that a defect in the tendon?
Yes.
That is then in continuity with the bursa, and to see vascularity within that would have disproved that.
It would have disproved that the fluid was coming from the tendon, or the other way around.
No, it would disprove that is fluid.
Oh, I've got you. Oh, okay.
Yeah. So I'm questioning whether the tendon actually has a hole in it or not.
I've got
or whether
you.
I'm just seeing a very low echo area of tendon.
I'm with you.
Focal pathology within the tendon. But and on balance, I would say I think this is a fissure within the tendon. I don't think that would necessarily change management, but it would make me much less happy about someone trying to, because people will sometimes try and convince me, sometimes successfully, to put some steroid if I see an abnormal bursa. But where I see that the tendon is the actual structurally compromised to the tendon at the same point, then that makes me much more reserved about whether I'm prepared to do anything to this tendon or to the bursa.
Because of the catabolics getting into the collagen of the actual Achilles.
Now, if you put steroid around the Achilles, I'm sure there's an element of that. But it's one thing to put a small dose of steroid into a bursa adjacent to a tendon. It's another one to essentially inject steroid into a damaged tendon. That strikes me as being, I don't think my insurance company would thank me for that one, and I wouldn't blame them. Now, this is just a rubbish scanner, but what I'm trying to show here is the Steeder process. This is a patient with posterior ankle pain.
The Steeder process, is that a pathology of a periosteal osteophyte, or?
It's usually it's a prominence and I haven't got Google handy, but
it's on the calcaneus.
It's a process on the back of the talus.
Oh, okay.
And it gets and it can lead to sort of posterior impingement, where it's a bit like, it gives a similar sort of presentation to a ostrigonum. So where you have something in the back behind the talus, and that
Oh,
impinges
okay.
in patients that with the plantar flex get pain on
Yes.
plantar flexion,
The
and sometimes
ballerina
and
type.
this steater process, yeah, and this steater process just looks a little bit untidy. But really didn't have a very good view of it, but you can just see there. And I can't remember why the views were bad on this case, but it was not great imaging. But I just was looking at that. But I will follow that up and see where we go with that.
What does that
And
mean? You have this patient come back in and evaluate?
no, we would, when I do audit at sort of around 18 months, and just check whether
Okay.
there's any
Okay.
outcomes. And this is a little bit slightly unusual. This is sternoclavicular joint, and just a little bit of swelling around the joint, which isn't not very uncommon, but this is synovitis around the margins of the joint.
Do you scan this as a component of your shoulder scans, or because the person
No,
came in saying, I have
patients
pain here?
they come in with swelling
All
at
right.
the shoulder.
No, don't forget you control the end of this session, John.
Yeah, yeah.
I have all day here, so oh,
Intramuscular lipoma. They're usually less bright than that. That's it's a less common one.
where is the location of that last one?
This one was in vastus medialis.
Okay.
Just a little unusual, but looks like a fatty lump. And this, all right. Now this is tibialis anterior. I was slightly skeptical. I wonder whether this is a ruptured tibialis anterior that has then scarred up a bit like an Achilles will, if it's left, because I find it hard to believe that you get a partial tear that would look like this, but it just thins right out. But then you feel like there's tendon running all the way down there of some sort, but it doesn't look like normal tendon at all. And so I think this is just ruptured back, and whether a few fibers were left. Sometimes with tib post, you get it behaving like that, where you get certainly bridging fibers across there. But I think if we go back right to the start, you'll see there's quite a lot of atrophy within the muscle. We can't see a lot of the muscle there, but it doesn't look like healthy muscle. So I think that's what we've got there.
I lost an MRI fight. I had a patient already scheduled for surgery with one of those, and I think that's what must have happened. And again, over here we surgery everything we want as soon as we can, and I think
Yeah,
it's
yeah.
the entirely different focus that over there.
Yes. Oh, yes, definitely. And sometimes it's you kind of feel both ways for it, because sometimes we think we're not active enough in these cases. So this is the last one, I think, where this is a previous
Rotator
fracture of
cuff
the greater
repair.
tuberosity.
Okay.
No, greater tuberosity fracture.
Sure enough. That's a good one.
Yeah. And I was saying that's me looking at what happens when because they're complaining they can't abduct the arm. And I'm saying, yeah, I can see, I think this previous fracture is what is causing the problem. But